Good evening, everyone. Today we're discussing a very, very important topic. It is my privilege to introduce the worthy speaker for today's talk, Dr. Supratik Bhattacharyya, who is a very highly accomplished endocrinologist and diabetologist with distinguished academic background, MBBS, MD, MRCP, FRCP, and so many other qualifications, and over 30 publications in very reputed journals. He also holds editorial positions and actively participates in research. Many of them are clinical trials, phase 3, phase 4 studies. Then Dr. Bhattacharya's achievements include prestigious awards like Inspire Endocrinologist Award 2022, Best Paper Presentations, and leadership roles in various medical organizations. He is a founder of AMOC, conference speaker and organizing chair. He has been of many conferences. His academic excellence extends beyond medicine with national level recognition in both secondary and higher education. I would like to discuss so many things about him. I would discuss some of the papers he has done, but then in the interest of time, let me not hold between you and Dr. Bhattacharya. So over to you, Dr. Bhattacharya. He'll be talking about an important topic of weight.
Thank you, Dr. Sadiq, for all your kind words of introduction and for this kind invitation to speak on this particular topic. And I'm looking forward to the discussion that we are going to have after this presentation is over. So I'm going to keep my presentation very brief. And so today we're going to talk in particular about the body weight as a risk factor for diabetes and cardiovascular disease. And just to set the background, we know that obesity in India is a growing problem. Obesity is a complex condition with increased subcutaneous and visceral adiposity. And we know from Dr. Chittaranjan Yagnik's study not very long ago that Indian phenotype is very different from our Western counterpart because we have what is known as the visceral obesity or abdominal fat. And for the same BMI, we have a higher fat percentage as compared to a Western counterpart. And that obviously is one of the causes for increased insulin resistance, which again is the underlying factor for majority of the micro and macrovascular complications and metabolic syndrome as we get to know about it. So associated with adipose dysfunction and insulin resistance, which increase the risk of diabetes and cardiovascular disease. In urban India, almost 3 out of 4 Indians are overweight. And this is probably because of the change in the lifestyle. We are becoming more sedentary, westernization of the diet, and a whole load of other factors, which is leading on to this increased burden of obesity and overweight issues. The prevalence of abdominal obesity was found to be 40% in women and 12% in men. And I'm sure it's steadily increasing over the number of years. Now, studies have shown that 5 to 6 out of 10 women between the ages of 30 to 49 are abdominally obese, and association of abdominal obesity in women is stronger with older age groups, urban residents, wealthier sections, and non-vegetarians. Now, we also know that Indians are at increased biological risk for cardiovascular disease because of our genetic makeup, and the major cause of death in India probably is cardiovascular disease, and we get it at a younger age as well. So Indians are known to have the highest cardiovascular disease or coronary artery disease rates, and the prevalence of coronary artery disease in Indians living in India is about 21.4%. for diabetic individuals and lower for the non-diabetics. But the prevalence of coronary artery disease in rural parts of the country is nearly half that of the urban population, and we just mentioned a few of the possible causes why the urban population is having a higher prevalence of overweight or weight issues. Again, diabetes in India is a growing problem. About 77 million people over the age of 18 years are suffering or living with diabetes, and over 90 million is living with a condition called pre-diabetes. And by the time it comes to 2045, India is going to become the diabetes capital of the world. So nearly 25 million people are pre-diabetic. The number is grossly low in here. The number is much higher if you screen properly. So we did have a campaign from RSSDI where we reached out to about 1 million people on the same day, and we screened for that, and we were absolutely surprised at the number of people who were having dysglycemia on a single particular day screening. Adults with diabetes have 2 to 3 fold increased risk of heart attacks and strokes. And if you want to link obesity, diabetes, and cardiovascular disease, so there's a condition, a term that has been coined, which is known as diabesity. And as we have established, there's a direct link between obesity and cardiovascular disease. And we have seen that the incidences and prevalences of coronary artery disease or atherosclerotic cardiovascular disease is much higher in the diabetic population as compared to those who are non-diabetic. So you can see in here a relationship between obesity, diabetes, and cardiovascular disease phenotypes. And this is a UK biobank cohort study. And you can see in here the numbers are higher in those with diabetes as compared to those without diabetes. And similarly, those who are obese versus non-obese, the chances of uh, dysglycemia or diabetes is much higher in the obese category and the overweight category versus the normal BMI category. So obesity, diabetes, and cardiovascular disease, and a number of mechanism has been proposed. We already mentioned about the insulin resistance, and this is probably the common soil for both the micro as well as macrovascular disease. And we know that because of the inflammation that is ongoing with the dysglycemia, and diabetes by itself is a pro-inflammatory state, and that leads on to endothelial dysfunction. And you can see in here on the left-hand side, you've been shown some adipose tissues releasing adipokines, resulting in inflammation. And then also you have the free fatty acids causing impaired oxidative capacities. There are certain aggravating factors, for example, aging, chronic disease, immobilization, inactivity, excess lipid intake, carbohydrate intake, for that matter. All of these would lead on to increased pro-inflammatory state, and also it will get in the way of the oxidation. So impaired oxidative capacities, reactive oxygen species being made, accumulation of lipid derivatives leading on to lipotoxicity. And both this inflammatory process that is ongoing along with the lipotoxicity results in insulin resistance. So on one hand, you have say impaired basal insulin secretion from the liver. On the other hand, you have a majority of the Indians, they have a large representation of carbohydrates on the plates, almost 60 to 70%. That leads on to a prolonged, prandial state. That also adds to the glucose burden, resulting in, insulin resistance. Again, you ultimately have a reduced quality and quantity of protein, and that affects the insulin production as well as insulin resistance. So on the right hand side, you see insulin resistance causing hyperinsulinemia, and this is the state where a person who is newly detected with diabetes, they don't have a grossly deficient insulin state unless there is a certain category in younger individuals who present to you with gross insulin deficiency. But in majority of the people who are overweight or obese, they have increased amount of insulin, but the insulin is not effective. And because of this hyperinsulinemia, you have increased MAP kinase activation leading on to accelerated atherosclerosis, also impaired PI3 kinase signaling, resulting in impaired muscle glucose uptake and impaired suppression of glucose production and development of type 2 diabetes. So if we want to prevent, we want to target all of these individually. In terms of obesity, we want to limit the unhealthy food, increasing the physical activity. So we talk about number of steps, aerobic activities, limiting the television time, on-screen time, improving sleep and reducing stress, about 6 to 7 hours of sleep and reducing stress. In terms of diabetes, we have to inculcate a good lifestyle change. If they're smokers, we have to ask them to stop smoking. If they take alcohol, we have to ask them to moderate the alcohol drinking. If they're overweight, we need to ask them to cut back on the body weight. So, physically active, at least 30 minutes of moderate exercise each day. Not only the aerobic exercises, but in order to prevent sarcopenia, we want to emphasize on the resistance exercises as well, which is very important. And eat a healthy diet. So cut back on the carbohydrates, increase the amount of proteins, fibers in the diet, and also cut back on the saturated fat. Cardiovascular disease, again, eating healthy diet, increasing physical activity, stopping smoking, and addressing individual parameters using appropriate agents to target blood pressure, statinization to address the lipids, and also to check the blood sugar to see if there is any dysglycemia and to address that as well. So there are multiple therapeutic strategies, and there are FDA-approved medications for weight management. Some of them are available in India. We are a bit limited in the space for managing obesity. Only uh, we have very little at this point of time to address only obesity, but we have robust agents at the moment which addresses diabetes as well as obesity. So it's easier for us. We have more choices for those individuals who are living with diabetes and overweight or obese issues, because the number of uh, molecules that are available to address that is higher as compared to those who are only living with obesity but no diabetes. So the FDA approved medications for weight management, short-term use of phentermine and diethylpropion, anti-hyperglycemic agents, as we said, initiating combination therapy to enhance preservation of the beta cell function. Approved for long-term use, Orlistat, this is available in India, phentermine, topiramate, bupropion, naltrexone. Again, the combinations are not that easily available in India. You can get the individual components. Again, liraglutide 3 mg, which is also known as Saxenda, never came to India. Gelesis is oral hydration gel. Again, it's not available in India. It comes to the stomach and intestine, absorbs water and expands, and thus reduces appetite. But the kind of side effects that we get in terms of the GI side effects, constipation, is considered to be very high as compared to the weight loss that we achieve. Uh, Setmelanotide is a specific agent which is indicated for managing genetic uh, obesity. So it goes and addresses few specific genes, for example, the POMC deficiency, then you have PCSK1 deficiency, as well as leptin receptor deficiency. So these three in particular are addressed by setmelanotide. And obviously, very recently, we have something known as semaglutide 2.4 mg or Wegovy, which is available over the counter in European countries and it's become very popular in terms of weight reduction. Now, in space where a person has diabetes as well as obesity is easier because the choices are many. We do have SGLT2 inhibitors, we have the GLP-1 receptor analogs, we have a combination of GLP and GIP, which is going to soon come to India, and then we are expecting a few other molecules or the combination of molecules with the GLP-1 receptor analogs, uh, like with the amylin precursors, like cagri-sema, which has the potency to bring down the body weight by almost 30%, which matches that of a bariatric surgery. So we do have a lot of interesting research that is going on in this space, and we're looking forward to the molecules that are going to come to India within the next couple of years or so. Now, talking about the HEF-REF population of heart failure with reduced ejection fraction, according to the AHA, ACC guidelines, directed medical therapies for heart failure with reduced ejection heart failure. We have now established dedicated heart failure trials with dapagliflozin 10 mg once daily, empagliflozin 10 mg once daily. So this has shown that SGLT2 inhibitors have a robust place in terms of heart failure management. It has become now one of the pillars for heart failure management. But what was interesting was that we were lacking in the space of preserved ejection heart failure or mildly reduced ejection fraction heart failure. And now we have dedicated heart failure studies with dapagliflozin as well as empagliflozin, which shows that SGLT2 inhibitor seems to be one of the rare class of drugs which we can use in preserved ejection heart failure space, because earlier the trials that were done with ERNI didn't turn out to be very you know, overwhelming, or it didn't show any positive results when it came to preserved ejection heart failure. So now we do have agents which not only addresses diabetes, which not only addresses the kidneys, but also can be used in treatment of preserved ejection and reduced ejection heart failure. And that is the SGLT2 inhibitors like dapagliflozin and empagliflozin, backed up by very robust data with them. So evidence-based study, 24-week international multi-center randomized double-blind parallel group placebo-controlled phase 3b study. A1C and fasting plasma glucose significantly improved from baseline with dapagliflozin, and more patients achieved a therapeutic glycemic response. Body weight and systolic blood pressure were significantly reduced from baseline over 24 and 8 weeks respectively with dapagliflozin. And then we talk about the power of combinations. And we had talked about treating or addressing diabetes based on the pathophysiology. And we have known about defronzose ominous octet. And we say that an incretin-based therapy, along with the SGLT2 inhibitor, probably addresses more number of this ominous octet as compared to the other combinations. And we do have some complementary modes of action as well as advantages of combining the SGLT2 inhibitors with the DPP4 inhibitors. So not only it's robust in terms of achieving the glycemic goals. So Dr. Kamlesh Kunti's group from UK showed that after the diagnosis of diabetes, unless we are very, very aggressive in getting the A1C down to the target levels within the very first year, there's a significant increase in the incidences of cardiovascular disease at the end of 5 years. So we already knew about the bad glycemic legacy from Wikipedia's VADT Accord trials, which shows that if you did treat the glycemia well, that you give them a better glycemic legacy that stays with you. But from this Dr. Kamlesh Kunti study, we know that if we're not aggressive enough, we do tend to have a higher incidence of macrovascular complications as well. So in general, the macrovascular clock starts ticking even before the diagnosis of type 2 diabetes. So advantages of the combination: it improves both insulin resistance and functioning beta cells. One increases the glucagon. DPP4 inhibitors, on the other hand, reduces the glucagon. DPP4 inhibitors boosts the endogenous GLP-1 by acting on the DPP4 inhibitors. DPP4 enzyme in general goes and destroys the endogenous incretins which are released from the L cells, and this is inhibited by the DPP4 inhibitors, and that increases or prolongs the action of endogenous incretins. On the other hand, SGLT2 inhibitors causes glycosuria, and in achieving that, once with the glycosuria, it also brings out some water. So because of that, there's diuresis, and that addresses the issues like if somebody is overweight or obese, they lose calories and they reduce body weight. They also have natriuresis, and that lowers the blood pressure. So there are multiple pleiotropic benefits that come with the SGLT2 inhibitors. The combination is considered very safe in terms of not causing any hypoglycemia and achieving a rapid and sustained glycemic control. We also know that as compared to starting a SGLT2 inhibitor with a very high baseline HbA1c, where we do see increased incidence of mycotic infections. If you start with a combination, this GTI or the UTI is much lesser because you are rapidly achieving the glycemic targets. It also aids in body weight and blood pressure reduction. We know that SGLT2 inhibitors cause a modest reduction in the blood pressure to the tune of around 4 millimeter mercury systolic and 2 millimeter mercury diastolic. More patients are compliant with the combinations. It's a single pill therapy. It's cost effective. Now we have the generic versions of the combinations which is available in the market. And lastly, I wanted to share with us the first study, real world study that we conducted with our group, which was a multicentric trial with the oral semaglutide. So the first study on oral semaglutide, which showed that the results coming in from the real world was very similar to the pioneers studies, and there was a robust drop in the A1C from the baseline by almost 2%, and there was also a robust drop in the body weight of around 5 kilos from the baseline. So we are having multiple real world studies, and it's always good to see when the real world data matches that of the RCTs, because it's always assuring for us. So I just wanted to conclude by saying that the proof of the pie lies in eating it. So please use these combinations, and you understand the power of these combinations to start off with. So with this, I hand back the session to our chairperson to take the further questions and discussions. Thank you.
Thank you, Dr. Bhattacharya, for a very excellent lecture on body weight and its relation to inflammation, obesity, and other components of metabolic syndrome. So I am sure there will be many questions, but I don't know how much time will tell, but let us take some questions. The first question is about inflammation. So, how does inflammation linked to excess body weight contribute to developing diabetes and heart disease? You did touch it, but maybe just to take home message on this, a brief reply would be sufficient.
Yeah, so I think we had briefly touched upon the issue that this pro-inflammatory state, you know, and production of reactive oxygen species, all of these adds up. And one of the underlying factors that we had talked about, and which is especially relevant in Indian context, is the matter of insulin resistance. And that would be the underlying factor for the metabolic syndrome, so as to say. So whether it's the diabetic dyslipidemia, obesity, whether it's the dysglycemia that we are talking about. So all of these will be at the common soil would be the insulin resistance and the pro-inflammatory state.
Excuse me. So, there are many these profiles of obesity-related metabolic profiles. So, are there different obesity-related metabolic profiles affecting the risk of diabetes and heart disease differently? Some profiles affecting diabetes risk, some heart disease, some both, or some do not have the risk.
Yeah.
Obesity-related
So
metabolic profiles.
again, I think the Indian phenotype, as we said, are at a higher risk of developing cardiovascular disease because of the phenotype that we have. uh, Again, falling back on the insulin resistance that we keep talking about, that is one of the reason for this abdominal obesity, is probably one of the factors that drives cardiovascular disease as compared to the western counterparts. So insulin resistance again seems to be the culprit, and the Indian phenotype, the thin fat phenotype, is the one uh, that is responsible for a higher incidence of cardiovascular disease in Indians as compared to the Western counterparts.
A new term is coming, concept of metabolically healthy obesity. It is a little controversial. So, can you discuss about it and its relationship with diabetes and heart disease?
Yeah. So
Metabolically healthy obesity.
yeah. So the thing is, you know, the, there has been a controversy regarding whether all the obesity needs to be treated. So there is a term called the metabolically healthy obesity, where a person seems to be obese, but they don't have any indicators for treatment of obesity because they seem to be living well with it. Now, that's why I think just going by the BMI is not good enough. So we need to have another assessing system or the staging system. So we do have the Edmonton obesity staging system that was developed back in Canada, which takes into account multiple parameters like the functional parameters, medical parameters, and they have multiple stages going from stage 0 all the way to stage 4. And if we see that a person falls in stage 0 for all of these categories, um, and although he has got a BMI which is considered to be in the overweight obese zone, then we might not need to treat it right away. But even a person who is having, say, overweight status, but they are in a high stage of the Edmonton obesity staging system, might require interventions in terms of medical or pharmacological therapy or surgical therapy. So that is a concept that is coming up, that you have to be uh, comprehensive. You need to take into account multiple things rather than just the BMI. But I think in Indian subtype, we need to consider the abdominal obesity as well. So abdominal girth is one of the things that we need to consider over and beyond just the BMI itself and the body fat percentage.
Right. Thank you. The next question is what weight management strategies effectively reduce diabetes and heart disease risk in high risk populations?
Beg your pardon? So,
What weight management strategies effectively reduce diabetes and heart disease risk uh, in high risk populations? Like we know weight management strategies, but we generally we target the weight loss. But are there
correct.
any weight loss strategies which effectively reduce diabetes and heart disease risk in
Yeah.
high risk
So
populations?
yeah, so those who are at high risk, so we now have very robust guidelines in terms of addressing the risk factors. So we do have agents which not only targets say diabesity but also addresses the cardiovascular risk factors as well. So we need to take them on board quicker, at an early stage rather than keeping it for later. So, along with lifestyle modifications and dietary changes, so we have seen from the direct trial that low calorie diet um, direct trial was done for around 2 years, which showed that there was a remission of diabetes of almost 89% at the end of 2 years, which significantly fell with the direct extension population because it was difficult to sustain that weight loss as well as the remission with only diet per se. So we need to have on board those kind of agents which can lower the set point and lower the chances of your cardiovascular event later on. And that's why we need to take on board agents like GLP-1 receptor analogs, SGLT2 inhibitors, which has shown multiple pleiotropic benefits, and as well as not only it gives secondary, it has a role in secondary prevention, but some of the trials that were designed to look into the primary prevention cohort, say for example the declare TIMI trial was addressing to a large extent the primary prevention cohort with dapagliflozin. And similarly, dulaglutide trial that we had, Rewind trial also had a major population from the primary prevention cohort. So those population who are living with multiple risk factors for cardiovascular diseases, we need to take on board these kind of agents earlier rather than keeping it for later.
Thank you. So, considering the time and resource limitations we have, what challenges do primary healthcare providers face in implementing weight management interventions?
Yeah, so as we said, India is a resource limited. Majority of the practices in India are resource limited, and we have to do with whatever best we have. So, for example, we are privileged. We have, body fat analyzers, which gives you body fat percentages. We do have access to the modern medications in terms of weight reduction, as well as getting to the glycemic goals. This might not be easily available in a primary care setting, so they have to fall back on a simple algorithm. So they have to routinely calculate it's easy now because through the apps you can calculate the BMI at least. And as we said, uh, the other surrogate markers, like we have to do a abdominal girth. If we can measure that routinely in a clinical practice in a resource limited place, we can at least do the body weight and the abdominal girth to begin with, and then have a simple algorithm. So for those individuals who are having obesity, or who are having diabesity for in general, we can use those molecules which are easily available. Like now we have the generic versions of the SGLT2 inhibitors, which are known to be uh, much cheaper than what it used to be. And also we now have, say for example, the biosimilar GLP-1 receptor analogs also, which are much cheaper. So maybe in the primary care settings, at least the early use of SGLT2 inhibitors, metformin, these kind of things can be emphasized on for those with higher risk to achieve weight loss.
Right. Thank you. So, what is your take on overcoming these challenges, especially in high risk populations?
So we need to be aggressive in terms of sitting and counseling the patients. We need to have this conversation early with the patient, and tell them it's easy now to do a risk calculation. We have many risk calculators to show the future cardiovascular risk. So if they have a high risk, they need to be statinized. They need to be having a good blood pressure goal. So we need to have a blood pressure goal for them and achieve that with antihypertensives if necessary, along with dietary modifications and lifestyle. Along with that, we need to address the dysglycemia with the appropriate agents that we had been talking about, which not only addresses the glycemia but also gives you a cardiovascular protection.
Right. Thank you. So, can you explain how advanced imaging techniques like MRI, spectroscopy, and PET scans enhance our understanding of the impact of body weight on diabetes and heart health?
So we are using this. So, for example, we use FIB4 scoring, we use DEXA scanning, we use MRI to look at the body fat in appropriate populations. Again, it's difficult in resource limited settings in India in majority of the places, but in tertiary care centers, we do look at the body fat with DEXA or MRI, and then we intervene accordingly. So, because of academic interests, many of the institutions they're using this MRI or the DEXA machines, but at least we know, we can use, many of the centers do use fibroscan after a FIFO scoring to address the issues of fatty MASLD, for example. MASLD is a newer term that we use, which used to be called non-alcoholic fatty liver diseases. And I think we need to screen for this. We need to be very proactive in terms of asking the right questions, getting a robust history, and also getting this FIFO score done on a routine basis, and then doing the scan if necessary to identify fatty liver. Because not only these fatty changes are bad for the liver, but they also have an implication on the heart as well. Similarly, we can routinely screen for the ACR, or the albumin creatinine ratio, and the higher albumin creatinine ratio, say micro or macroalbuminuria, is not only a risk factor for the kidney, but also they can uh, be a risk marker for a future cardiovascular event as well.
Thank you. So, how can primary care physicians address cultural and socio-economic barriers, which are additional challenges we have, that may hinder patients' ability to engage in weight management and lower their risk of diabetes and heart disease? So, challenges in terms of socio-economic barriers that hinder patients' ability to weight manage.
So, I mean, this is a big issue, like there are multiple concepts or, beliefs uh, that get in the way of, counseling the patient, or they have a certain food habit which is very, very difficult to change, like, so if you suggest something which is radically different from their eating pattern, I think that is not going to be well taken. So we need to understand that, and we need to, adjust in such a way that it simulates, or it is very close to whatever dietary pattern or lifestyle that they are usually used to in general. So you need to have a good team. So sometimes the physicians are very busy; they don't have the time to counsel each and every patient. So that's where you need a team of counselors who sit with the patient and they talk to them about minor adjustments in terms of, carbohydrate limitations, following the same dietary pattern, and also the kind of feasible lifestyle and lifestyle changes that they can adapt, as well as in general, if they're sedentary, we need to introduce a some sort of an exercise regime in terms of aerobic exercises. And we did mention about the sarcopenia issue, which is common with the diabetic patients. So we need to have some amount of resistance exercises as well for them.
Thank you. Last but one question. How can primary care physicians effectively communicate to the risks of obesity, diabetes, and heart disease to patients in a way that motivates behavior change? Communicating the risk of obesity related diabetes and heart disease to patients.
How do they communicate with the patients?
Yeah,
This
yeah.
is
How do they effectively communicate so that they feel motivated for the behavior change? Because ultimately it involves a behavior change, and
absolutely.
we have so
So
many challenges.
So as I say, I mean, it's never a easy task, and especially for a primary care physician who is probably going to cater to a huge number of patients. They must be seeing much more patients than we usually do in the cities, and so to have an individual conversation with the patient might be a challenge. But somehow I think they have a better understanding of their socioeconomic status, and I think that goes a long way. So you need to have that conversation, understanding the patient, not being condescending. So you can't tell them what to do. So you need to uh, take their opinions as well, and you have to ask them to be on your team. So it's you have to explain to them, the way I do is that it's going to be a team effort where me, you, and my counselors are going to be part of the team, and we are going to work with you in terms of the challenges that you're going to face on your day-to-day life, and keep communicating with us, because it's not going to be a one big leap. We're going to take small steps to achieve whatever goals we have in mind. So I think that is a more realistic way to go forward, rather than making major lifestyle changes or major dietary modifications.
Right. Thank you. So the last question. When we present data, it is all from cohort studies, but there are some limitations. So, do you agree there are any limitations cohort studies linking body weight, CVD, and diabetes, such as underrepresentation of the certain patient groups, such as women, and how can these limitations be addressed? When we
Yeah,
have
so as
cohort
we
studies
said,
which lack some of the basic things
so,
which you like to know about certain populations, like
yeah.
underprivileged, women, other things.
So as we say, like we had been talking about complementing the RCTs along with the real world studies. So this is very, very important. So there are going to be lacuna, there are going to be some gray areas where the data is going to be deficient, or so that has to be complemented with the real world studies. So we can address those areas by having a robust real world study to look into those aspects. So if we feel that in a particular randomized controlled trial, a particular subset of population has been underrepresented, maybe we can take that up as a real world study and generate data in that regard.
Thank you. That was the last question. Thank you very much for beautifully explaining all the aspects related to weight management in the given time. So with that, I hand over the mic to back to the organizers and also the screen. Uh, I'm
So
sure.
before that, I want to thank you, Dr. Masoodi, for conducting this particular interview so nicely, and I think hopefully this session would have been value adding for those who had been listening to us. And I want you to give your take on obesity, maybe in a single sentence to wrap things up in general.
I think this is the biggest challenge we have. Whatever diseases we talk, be it diabetes, be it heart disease, be it cancer, the basic link, connecting link is obesity, and that is related to our lifestyle. People have to understand that this is a chronic disease. Most of the people look for shortcuts. This is a chronic disease. Whatever we do, whether we do lifestyle changes or whether we want to go for any other modifications, this has to be lifelong. So unless people understand that this is a chronic disease and this is going to stay, whatever factors we have, whether it is genetic or whether it is environmental, they are there. They are not going to change. So people usually look for shortcuts. There's no shortcut in this. So you have to accept it as a limitation of the modern lifestyle, so-called civilization, modernization, and this is the limitation. So we have to accept it and accordingly address. I understand that in different people, different things work. In some people, diet doesn't work. In some people, exercise doesn't work. But perseverance is the key. You have to be consistent. Then only you will get the desired results. And because initially there are no symptoms, unless you look for it, you will not find it. Whether it is heart disease, blood pressure, kidney disease, liver disease, fatty liver disease, uric acid, all things, women, PCOS, OSA, unless you look for these things, you will not know it. So is a mammoth of a problem, is an epidemic, is a global epidemic, and this is a kind of malnutrition, and we have to address it. The sooner we address it, better it is.
Thank you so much.